Just ahead on this edition of Being Well, we'll be talking about non-healing wounds and their treatment. Our guest is Dr. Kelly Jones Monahan from Sarah Bush Lincoln Health System. We'll talk about what causes a non-healing wound, who's at risk, what are the symptoms, and what treatment choices are available, including the use of a hyperbaric chamber. That's all coming up next on Being Well, so don't go away. Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Additional funding by Jazzercise of Charleston. Hello, and thanks for coming back to Being Well. I'm your host, Lori Casey, and today our topic is advanced wound care. And my guest is Dr. Kelly Jones Monahan with Sarah Bush Lincoln Health System, a general surgeon. We've had you on this show before talking about gallbladders. Yes. Today it's all about wound care. And when we talk about in this realm of wounds, we talk about non-healing wounds. So what sort of puts a wound into that classification?
Well, obviously this is more than just I skinned my knee, rollerblading. Most of the wounds that we talk about that are non-healing have little improvement over a 4-week period and are not completely healed at 8 weeks. So we're talking about something that has been going on for a while.
So this is far behind, you know, I've scratched myself and it just doesn't heal. Right. So it's a little more than that. Right. So what diseases or ailments can be associated with non-healing wounds?
The most common patients that we see in our clinic are patients with diabetes and what we call venous stasis ulcerations. Okay. And basically that's the patient who has the varicose veins, but it's beyond that, where they have swelling, they're darkening of the skin of the legs, and that causes breakdown in the skin. And those are the most common things we see. Other wounds can be due to pressure ulcerations in patients who may have neurologic problems such as paraplegia, elderly patients who may have sit or lain in a position for long term, or immune problems.
Okay. So when wounds don't heal, what is the body not doing or is unable to do?
Well, there's a couple things. One is a lot of times there is debris in the wound that just prevents the healing process. It's kind of like dumping garbage into a pond and expecting grass to grow over it. It doesn't really work. So, and sometimes it's bacterial load. It may not be an infection, but there's too much bacteria in a wound to allow the normal healing process to occur.
Okay. And why is it that we see, diabetics are typically at higher risk for non-healing wounds?
Well, one thing we see, it's very common in the feet, and that's because many diabetics have what we call diabetic neuropathy. The high levels of sugar in the cells actually cause the nerves to short circuit. So they tend to feel different types of pain than would be normal, but they also don't have good sensation. So they can step on a rock and not feel it and get a deep bruise, and then their healing process doesn't allow that to heal, and then all of a sudden they have a hole in the bottom of their foot.
And they don't even know it. And is it too late then? Or
no, it's not. Okay. The big concern is that when they don't notice it, how long do they let it go before they seek treatment? And there are concerns about infection that can ascend into the bone and the deeper tissues. But certainly we treat a lot of diabetic ulcers, especially on the foot, that heal with close personal attention, time, debridement or cleaning up that wound, and other modalities as well.
So can a normal, healthy person be afflicted by a non-healing wound?
Certainly. We can see this. There tends to be some other issue going on. For example, we may see it in someone who's fractured a leg or an arm. They may have hardware in, pins or some other hardware that may make that a problem with healing. Most of the time, we're looking for some underlying problem. Most normal, healthy people are going to heal a wound in, with normal wound care, keeping it clean, keeping it covered.
So what happens if someone has a wound, like one of these non-healing wounds, and it's left untreated? What's the absolute worst case scenario that can happen if it goes too far?
Certainly worst case scenario, if you're talking in we deal with a lot of extremity wounds, especially feet, is that they can get an infection in the bone, which could cause limb loss. In other words, they could lose the toe, the foot, the leg. And those are worst case scenarios, obviously. In some situations, they can get infections, which we see this many times in the pressure ulcerations in the back, where the tissues have died, and then the infection then sort of what we call ascends and spreads elsewhere, and then become very ill associated with that.
So. Can those infections lead to like blood infections and infections? I mean, can it get really, really bad?
They can spread elsewhere. We do see some infections that can spread to the spine. Obviously, the bacteria can spread into the bloodstream and could seed other organs. It can show up in the heart valves, pneumonia. We see a lot of urinary tract infections in patients with pressure ulcerations. Sometimes it's hard to tell which came first, the chicken or the egg, whether the urinary tract infection caused debilitation and then the ulcer, or vice versa.
Okay. So are there, you're a general surgeon, and I know you do lots of different surgeries and wound cares. Are there specialized training that people who deal with advanced wound care go through?
Sure. When I went through a general surgery residency, this was not, we have rotations in a lot of different things, but specific wound care, other than, dealing with burns, isn't really focused on. We don't want wounds. We close things up, and they should always stay closed. What we do in our center is that we send the physicians to a wound care seminar in San Antonio, Texas, and that also includes hyperbaric oxygen therapy treatments, which we also get trained in so that we can do those therapies as well.
So run us through the process. If someone, patient sees their general physician and they've got a wound that's determined that it's more advanced, how does the treatment plan work when they come to see you?
Sure. Basically, I see the patient in the office. The nurses see them and take an extensive history. Then I go through a lot of their medical problems. Do they have diabetes, and what do their blood sugars run, et cetera. I do a physical exam. I evaluate how's their sensation. I look at the wound specifically, and then from there, usually it involves debridement, and that's the fancy word for I'm going to clean it up. And that's usually the first day in. Most of the time, most primary care physicians are not comfortable poking and prodding and scraping and so forth. And fortunately, we are. We numb the patient with topical creams, and we'll do biopsies of wounds as appropriate. But basically, the first thing we do is kind of see what's underneath all the stuff on top, see what the wound bed looks like, get cultures if appropriate, send tissue to pathology, and then we make a plan. Decide what kind of wound is this, what kind of treatment do we need to start with this, whether it's compression where we're squeezing the legs to prevent venous pooling, whether it's getting their sugars under better controlled, whether it's offloading, which means a lot of people, we need to get them off of the foot, the bottom of the foot, so they're not walking on their ulcer. And once you offload them and you keep them clean, a lot of times they'll start healing.
So talk about how the treatment has evolved, because there's some new technology out there. You said you do some debridement. What other kinds of treatments do you do?
Well, in the old days, we used to say keep the wound dry, open to the air. Shouldn't I leave this open so it will get some air to it? And what we find is that cells actually walk across a wound bed better if it's moist. It's like tadpoles moving across a pond. They move across much easier if it's moist. So we try to keep the wound bed moist. So we use things like colloids, which are fancy names for gels, like KY is a colloid, keeps the wound soft. Then we do certain types of topical dressings. We'll use honey. Honey's actually been shown. Regular honey. It's a medical grade honey. But honey has antibacterial properties and has some wound healing properties. There are certain dressings that we use that have what's called metalloproteases, fancy names for enzymes that help cells move and break down the bad stuff. And then finally, hyperbaric oxygen therapy, which has been looked at in poor light over the years because it's been used for all sorts of craziness, such as Michael Jackson sleeping in a hyperbaric oxygen therapy chamber. But what hyperbaric oxygen therapy does is it increases the oxygen to the wound.
Which is that what makes it heal?
And that's what makes it heal. Oxygen overall is the thing we're often lacking in many of these wounds. We talk about vascular wounds a great deal when people have low blood flow. Even if you reestablish blood flow, there's only so much it can do. With hyperbaric oxygen, it's like pushing more oxygen into the cells, even more than all the blood could deliver. And that increases the healing process. And for some people who've had radiation therapy or who have diabetic ulcers, or who have vascular ulcers, this can be very helpful in healing, whereas other modalities alone wouldn't.
So how does the hyperbaric chamber work? We have a picture of it. You know, it looks like a chamber of sorts, but how does, is it just like a bunch of, it's just pure oxygen in there, or how does it really work?
Well, it's a capsule. It has plexiglass around it, and you basically, quote unquote, dive. So what happens is the pressure in the chamber is increased to anywhere from 1.5 to 2 atmospheres. So in other words, the pressure around you is like diving underwater 15 to 30 feet. And by doing that, that dissolves more oxygen into the atmosphere and then eventually into you. So you're breathing it.
Like just, you breathe it in. That's, it doesn't get sucked in through your skin.
No.
You breathe it in.
Yes, you breathe it in, and then what happens is the science of it is the oxygen is sort of forced into the tissues at that higher pressure, and it gets to the tissues in a higher concentration. People take time to dive or go down, so the pressure is slowly increased, and the same thing happens when they come up. It's like surfacing from underwater. You can't do it very quickly because that can cause what we call barotrauma. Some people, as you know, if you've ever dove, your ears will pop. So some patients need ear tubes like we put in kids to help equalize that pressure. Some people will get some sinus pressure if they have problems with sinus, and we'll use Afrin to help open the sinus passages. Worst case scenario is you can get a collapsed lung, although that's very, very rare. And over time, some people may notice some vision changes, which are reversible. So,
I mean, when we think of hyperbaric chambers, you think of divers. You know, if they get if they come up too fast from the water, they've got to go in that to get pressure regulated or repressurized. So does the whole person go in there?
The whole person goes in. There's a couple different types of chambers. We have a mono chamber, which means you go in all by yourself. There are multi-place chambers where multiple people go in at the same time, and actually the person who runs the chamber is also in with you as well, and they dive with you and they come back up. There's advantages and disadvantages. Obviously, we can get to patients very quickly there. In multi-place chambers. The mono chambers are nice because they're just, they're private and they're easy to deal with. You don't need a huge room to manage it.
So how long does someone dive or go in the capsule
for? Most recommendations for are usually about 90 minutes to 2 hours for our quote-unquote dives. And then treatment lengths can be anywhere from 20 to 40 treatments overall. And on average, it's about 30. And it depends on their diagnosis and how well they're doing.
So does the person, when they're in there, do they feel any different, other than you said some of that pressure in the ears and the sinuses?
They notice a change in temperature. They'll get a little colder. So they usually have a blanket, and then they get warmer as they come up. Because it's a higher pressure of oxygen, we worry about fire. So we basically keep, there's no makeup, no lotions, no, you can't bring your iPad or a book in there. And they have a blanket in their gown, pretty much.
So they just hang out in there for the
watch television. There's a television on the outside that a lot of them take a nap. And the time passes pretty easily. Most people do well. First off, many people are concerned about the closeness of it, about being in something enclosed. But most people find that they do well. We introduce them to the chamber, have them look at it, get into it without diving, seeing how it feels and so forth to make them more comfortable.
So if they have on average 30 treatments, at what point in those treatments do you really start to see something significant in the healing of the wound?
Usually at the first 5 to 10, we definitely see an improvement. I've had a number of patients, the diabetic wounds, where we put them in the chamber and they, not a whole lot's happened, and then all of a sudden we really see a lot of improvement over time. A couple of them, it's been amazing. We put them in, and within, we see them back. In our office, we see them back every 1 to 2 weeks, and by the time we see them again, they've had 7 to 10 treatments, and wow, you can really tell.
So a non-healing wound is something that it's been around for at least 4 weeks.
At least 4 weeks.
So how long does it take for one of these wounds then to heal once you've kind of got the treatment plan going?
Well, this is the thing about wounds, is that most of these patients have a chronic disease that we're not going to be able to cure. So it takes a lot of vigilance outside the wound center as well. Some of them can recur, venous stasis especially.
Which is
so
what?
That's when the blood pools in the legs. Oftentimes the patients will get a dark pigmentation of their legs. They'll have what we call brawny edema. It's really sort of thick, woody almost. And the fluid pushes into the surrounding cells and then leaks out, and then they get ulcers from it. Once those things happen, you can't reverse that problem. So you have to sort of be vigilant to prevent it. We will often see someone heal a wound when we start seeing them within 1 to 3 months. And it sounds like a long time, but many times we see patients who've had these wounds much longer than even 1 to 2 months.
That's what I was going to ask. Are you seeing, is that you're seeing people pretty far into the disease process?
I think it's getting better now that we're here and people are more aware of it. I think what had happened originally were that physicians said, okay, we'll give this a try, and didn't really know where to go from there. So now that they're aware that we're available, we're seeing them a lot sooner, and makes that a lot easier for us to manage.
If you're a person that is at high risk for advanced wounds, or maybe you're a caregiver of a person, what signs and what sort of things would you recommend they look for, or kind of a practice to get into?
Sure. Every diabetic should be told about foot care. You should never walk around barefoot, ever, if you're diabetic. Even if you're getting up in the middle of the night to go to the bathroom, you need a hard-soled slipper or shoe to slip your feet in. And you should check your feet every day to make sure that you haven't stepped on something, that there isn't something new. For pressure ulcers, caregivers need to watch rotation. You need to really rotate people so they don't stay in one place. Neurologic patients or elderly patients who don't have that sensation to move need that help. For venous stasis, what we say is compression. You should be wearing a stocking, something that's going to keep the blood from pooling. Try not to stand long periods of time. Walk, keep your legs elevated. Higher than your heart if you can. It's sort of an upside down position, but really compression is the most important thing for venous stasis.
So if debridement doesn't work, the hyperbaric chamber doesn't work, is surgery the last option to kind of get in there and cut some of that out, I guess?
In some of the situations, yes. We do some debridement in the office, and again, those are things that obviously the patient can manage and handle from a pain standpoint. Sometimes we need to take them to the operating room and become more aggressive. Sometimes it requires revascularization, where we find that the blood flow is not appropriate or is not enough. So they might need a bypass where where you're reconnecting some blood so we get blood flow. Finding those things, and in some situations we can't heal an ulcer, and then we talk about what we do for that. And for some people it's limb loss, unfortunately. We try very hard to help prevent that as much as we can. So, but it's a multi-modality. I do way more internal medicine in this job than I ever do as a surgeon, because I'm asking all these questions. What is your sugar today? What has it been running? What is your diet like? What shoes are you wearing? What's your blood pressure today? Those sort of things.
So really the patient or the caregiver really needs to kind of keep on top of it on a daily basis.
Yes.
So at what point, when should someone really seek medical help, do you think?
From my standpoint, for us, of course, I see the continuity of this from I have a blister today to I have a wound I've had for 6 months. So from my standpoint, if you have something that's not healing, and it's not healed in a couple weeks, you need to see your physician, whether or not it's ready to go to something like that. A non-healing wound can also be a sign of other things, like skin cancers can present as non-healing wounds, such as melanoma or squamous cell cancers. And it looks for an underlying problem of, is there infection? Is there a deeper infection? So a couple weeks of, hey, I've got this something and it's not getting better, or wounds that get bigger, that started small and they're getting bigger, you should seek medical attention.
So if you do have that just basic wound care, keep it covered?
Yes.
Some sort of like antibacterial something on it, or just lightly covered with gauze? Or
from a standpoint of, if you have just I cut myself, I have a wound, it's not something I necessarily need to seek medical attention, wash with soap and water. You can apply an antibiotic ointment to it and then a cover of some sort. Usually we recommend that you change the cover every day. Most people can shower and let the water run over those every day. Hands are a difficulty because when you're washing your hands so frequently, the dressings get wet, so you need to change those fairly frequently. But keeping it covered is the most important thing.
So the opposite of
what
the old wives' tale of letting it breathe and leaving it open. Well, Dr. Jones-Monahan, is there anything else that we need to know that we haven't covered today?
I think from a standpoint of education, I'm always very surprised when I tell patients that they need to monitor their medical problem, their diabetes. I said, you should never walk without shoes. And they look at me like, really? No one's ever told me that. Blood sugars should be maintained less than 200 because white blood cells don't work. So I think education is a big part of this, telling people how to take care of themselves and help prevent this, I think is the most important
before
thing.
They have to seek more advanced care.
Yes.
Well, thank you so much for coming back to Being Well. We hope to have you on again. Thank you.
If you are one of those people at the grocery store who only reads the front label on food packages, well, listen up. You might not have a good understanding of what you're getting. In today's Health Minute, Holly Furfer explains.
Grocery shopping can be about getting in, getting what you need, and getting out. But are shoppers buying what they think they're buying?
If they're only reading the front of the package, many times they're not. Manufacturers are really good at picking up on those buzzwords that consumers are concerned with, and they use those to catch our attention.
A few common misconceptions. First, bread labeling can be tricky, says registered dietitian, nutritionist Ann Dunaway Tay.
Although it might say wheat or multigrain, it doesn't mean it's a whole grain bread.
You want to look for it to say 100%. Also, the term light can be confusing. It can be spelled two different ways but mean the same thing. Light can mean less calories, fat, or sodium than a food's original counterpart. But
just because a label says light does not mean that it's licensed to eat more of that food.
And trans fats. Many manufacturers have removed these bad fats from foods, but not all of them have done so. Just because a food says 0,
by law, it can contain up to half a gram of trans fat and still claim 0 on the label per serving.
You want to look in the ingredients for the words partially hydrogenated oil, the major source of trans fats, and steer clear of those items. Being a proactive and informed shopper can go a long way. For today's Health Minute, I'm Holly Furfer.
Cervical cancer was at one time the most common cause of cancer death for American women. But after 1955, the death rate from cervical cancer went down. The main reason? Better screening.
Even though more than 12,000 American women were diagnosed with cervical cancer last year, it's still the easiest female cancer to prevent because of two main tests. The first is the Pap test, or Pap smear, which detects precancerous cells in the cervix. It's the gold standard of cervical cancer prevention. The Pap test is recommended for all women aged 21 to 65 years, although the cancer has a tendency to show up in midlife. The second is the HPV, or human papillomavirus test, which looks for the virus. Almost 99.9% of cervical cancers are caused by HPV. If you get an HPV test with Pap, the cells collected during a Pap smear will be tested for HPV in a lab. Talk with your doctor whether an HPV test is needed. In some cases, an HPV vaccine may be recommended. But keep in mind the Pap test and the HPV test only screen for cervical cancer. Neither test detects for ovarian, uterine, or vaginal cancers. For today's Health Minute, I'm Holly Furfer.
Production of Being Well is made possible in part by Sarah Bush Lincoln Health System, supporting healthy lifestyles, eating a heart-healthy diet, staying active, managing stress, and regular checkups are ways of reducing your health risks. Proper health is important to all at Sarah Bush Lincoln Health System. Information available at sarahbush.org. Additional funding by Jazzercise of Charleston.